Good morning, everyone. I'm going to present on the refractory hepatic hydrothorax, the prognosis and the management. This is a schematic diagram of the diaphragm as we see here, and because it has got an important role to play analysis of hepatic hydrothorax because of the holes which are present predominantly on the right side of the diaphragm, through which the fluid passes from the peritoneal cavity into the pleural cavity. This is the outline of my presentation. Now, there is no well-defined definition of the refractory hepatic hydrothorax, but since the pathophysiology of refractory ascites and the hydrothorax is the same, so the similar definition can be also extrapolated to the definition of hydrothorax as well. So, it should be symptomatic, and either it fails to respond to the maximum dose of diuretics, that is, it is diuretic resistant, or the side effects arise precluding the maximum doses of diuretics, that is, it is diuretic intractable, and also it requires at least once thoracocentesis of more than 500 ml, and in some studies it is also said that it should be more than once in 2 to 3 weeks to achieve symptomatic benefits. Whereas there is large amount of data in the management of patients with refractory ascites, there is little data regarding the management of refractory hepatic hydrothorax. This is a recently published study in which it was found that compared to refractory ascites, the cumulative incidences of liver-related deaths are much more in patients of refractory hepatic hydrothorax. And when these patients were segregated at various MELD score levels, and it was found that compared to refractory ascites, the hazard ratio of liver-related death was more than 4 times in patients with refractory hepatic hydrothorax. So, these patients are much more sick as compared to patients with refractory hepatic hydrothorax, refractory ascites. Still, although there are no standard MELD exceptions given to these patients, the OPTN guidelines state that the MELD exceptions could be given on an individual basis, provided the frequency of thoracocentesis is more than 1 liter at weekly in the last 4 weeks, and there is contraindication for the TIPS in these patients. Now, coming to the mechanism, there is no well-defined mechanism which has been conclusively proven, but the most important ones are the defects in the diaphragm, which are typically less than 1 centimeter, predominantly in the right side of the diaphragm because it is more tendinous, because it is close relation with the bare area of the liver, and the left is more muscular. So, the defects are predominantly seen in the right side of the diaphragm, and it has been shown in the autopsy studies as well in non-liver disease patients that the defects are more in the right side, and the frequency is close to 20% in the general population. So, depending upon the types, they have been divided into 4 types. Type 1 is the no obvious defects seen on thoracoscopy. Type 2 is the most commonly identified defects in the form of bleps we see here in the parietal pleura. These are actually the herniation of the peritoneum through these defects because of the chronically increased pressure in the abdomen because of the ascites, and also the malnutrition which leads to thinning of the diaphragm. So, when these bleps rupture, there is continuous leakage of the fluid from the peritoneum into the pleural cavity because of the pressure difference, which is positive in the peritoneum and the negative intrapleural pressure. It favors the movement of the fluid from the abdomen into the pleural cavity. Type 3 are the fenestrations, as we see here, the beaded appearance on the parietal pleura on the surface of the diaphragm. Importance of this classification is that the type 2 and type 3 are relatively more common and are localized. So, therapy in the form of suturing can be done on these patients compared to the fourth one, which is the multiple gaps in the diaphragm. As we see here, this fluid is seeping from these multiple gaps which are generalized, and they cannot be simply treated by the suturing of these defects, and some sort of generalized process in the form of mesh repair or flap repair is required in these patients. Fortunately, these are rare. Now, coming to the management of the refractory hepatic hydrothorax, I am not going to discuss about the salt restriction or the diuretic dose optimization or the methods of examining whether the patient is salt compliant or not by the urinary analysis. Specifically, I will be focusing on the management of the hydrothorax which is refractory in nature. The first one is the removal of the fluid from the pleural space, which is the easiest one to do. The repeated thoracocentesis, it brings about the prompt relief of this patient, but because of the negative pressure in the pleura, there is rapid refilling as well. So, multiple sessions are required in these patients, and it has been shown that compared to patients who are having non-liver disease, patients of hepatic hydrothorax have a cumulative increase in the risk of complications in the form of empyema or bleeding or other sorts of complications are there. And in this study, it was found that the risk of hemothorax was more in patients who had platelet count less than 50,000 or high MELD score. Chest tube is a strict no in the patients of hepatic hydrothorax because of the various complications that it can give rise to. Nearly 88% of the patients develop complications in one study in the form of bleeding or empyema or pneumothorax, and also the mortality is very high. In this study, it was found that compared to a thoracocentesis, the risk of mortality was more than 2 times in patients who had chest tube drainage. Now, pigtail is our favorite, which commonly do the ICD drainage with the help of pigtail. These are small caliber tubes, 8 to 10 French, and are coiled at the end to prevent the accidental dislodgement. And in 2 studies are there. This is the recent one studies with fairly good number of patients. And in this study, it was found that the readmission rate due to the hepatic hydrothorax was similar in the pigtail catheter drainage as well as the intermittent thoracocentesis. And also the complications in the form of hepatorenal syndrome or the procedure-related complications were less in both the groups. Interestingly, in these 2 studies, the pigtail catheter was allowed to drain continuously under albumin cover. So there was no clamping done, which we commonly do here. And it was found that after a median of 8.4 days, nearly 50% of these patients underwent spontaneous pleurodesis, which was something new when I read this paper. And also the probability of survival was similar in both the groups. Now coming to another modality, which is indwelling pleural catheter placement, which is a common mode of palliation in patients with malignancy-related hydrothorax. And in this, as we see here, these are the tunnel. This is the catheter insertion site, and the fenestrated catheter is placed into the pleural cavity, and subsequently it is tunneled under the skin and this comes out through the skin and is then connected to the tube here. So depending upon the patient's symptoms, it can be opened and brings about the effective palliation. This is recommended only for the patients with malignancy-related pleural effusions. However, in 2017, it was also US FDA approved for the patients with non-malignancy-related pleural effusions which are refractory to the medical treatment. Now, this is the only multi-center study which I could come across. The 79 patients were there. The clinical success was 100%, and the mean dwell time of IPC was 156 days. And the most important reason for the removal of the IPC was the death of the patient, because it does not take care of the underlying disease process. And also, interestingly, spontaneous pleurodesis was seen in 28% of the patients after a median of 55 days. However, majority of the patients actually underwent liver transplantation within this period, so this rate of pleurodesis may be slightly over-exaggerated. Interestingly, the infection was relatively less, only 10% of these patients. Out of 8 patients, 2 patients died because of septic shock. Still, it is a much safer mode of modality compared to the chest tube drainage. Pleurovenous shunts have been quite popular in the early 1970s for the treatment of malignancy-related ascites and pleural effusion. The initial one, 1974, was the leave-in shunt. We see 3 parts are there: the perforated peritoneal tube, which is having fenestrations. The one-way valve is there, which opens with pressure gradient as little as 3 to 5 centimeters of water, and is draining into the venous catheter, which subsequently drains into the superior vena cava or the IJV. So because of the ascites, continuous flow of fluid is maintained here across this wall and brings about effective palliation. But patients with pleural effusion have got a different physiology, because both the fluid and the venous chamber are in the same compartment. So the pressure difference between the two is less. So the downward shunt was then devised in 1979, which also had a manual pump. So apart from the valve, pump is there. Patient had to pump it multiple times in a day to bring about effective flow of fluid from the pleural cavity into the venous circulation. But they were predominantly for the patient with malignancy-related ascites and pleural effusion. However, certain studies have been there. This is the CT scan of the patient showing the pump there in the subcutaneous space and the one-way valve in the pump, so that the preferential flow is towards the venous system. And very few studies actually are there in non-malignancy-related effusions. This study published way back, 12 patients were there, out of which 6 patients were of hepatic hydrothorax, which was resistant. And we show the X-ray pre-procedure and the post-procedure showing effective drainage of the fluid. The other mode of action could be reduction of the production of the ascitic fluid. In this, terlipressin, midodin octreotide, or albumin may be helpful, but very small data in the form of case reports or very small case series are there. In this group, the most important one is the TIPS. Unfortunately, where there are 7 RCTs and 8 meta-analyses for the treatment of refractory ascites. There is only few retrospective studies are there in patients with refractory hepatic hydrothorax. This is the largest study published way back in 2010. 73 patients were there. The mean pre-TIPS MELD was 18.5. There was effective pressure reduction seen, and the 1 month response rate was in nearly 80% of these patients. And the 30-day mortality was 20%. Pre-TIPS creatinine was the independent predictor, and the survival at 1 year was only 48% in this study. And pre-TIPS MELD and the complete response were the independent predictors of the survival. Incidentally, only 26% of these patients actually received the covered stent in this study because it is an old study. But when they analyzed the type of stent, it was not found to be statistically significant with regard to the clinical response or the survival advantage. MELD cutoff of 15 was identified in this study with regard to the improvement or worsening of the survival. This is much lower than the cutoff of 18 when we analyze the patient for what is the data for refractory ascites. The data for ascites shows that MELD 18, if it is there, more than 18, it worsens the survival. Less than 18, it improves the survival. But for the cutoff is 15 for the refractory hepatic hydrothorax, again emphasizing that these patients are much sicker compared to ascites. In various studies, it has been shown that the 30-day mortality rate varies from 20% to as high as 68%. And this is our data from ILBS, where the largest number of patients of effusion were analyzed. Nearly 1,200 patients were there. And interestingly, nearly 12% of these patients actually had tubercular pleural effusion, emphasizing the importance of analysis of the pleural fluid in patients with cirrhosis with effusion. And also to see when a patient is not responding properly to the diuretics and salt restriction, one should always rule out other causes. And also, if the effusion is left-sided or it is bilateral, then one should have a high index of suspicion to rule out other etiologies of effusion as well. 667 patients, 949 patients were there with the hepatic hydrothorax, out of which 30% patient had refractory hepatic hydrothorax. 51 patients were carefully chosen for the covered TIPS. These patients actually had a lower CTP and MELD score 18.7 compared to the ones who underwent thoracocentesis or the pigtail drainage, where the MELD was 22 and 23. So despite adequate reduction in the pressure, only 10 patients had complete response. That is, nearly 20% patient had complete response, and 25 had partial response. No portal pressure reduction threshold was identified as a predictor of the response. 6 months mortality was also quite high, 40%. And there was no difference in the 6 months mortality with regard to the mechanism of the drainage procedure in this study. In this meta-analysis, 6 studies were analyzed, nearly 200 patients were there, and the complete response was seen in nearly 50% of these patients, and the partial response nearly 20% of these patients. And the 45-day mortality reached 20% roughly, and nearly by the end of 10 months, 50% of the patients died. And the incidence of encephalopathy was seen in nearly 12 to 15% of these patients. The other mechanism for treatment in these patients could be prevention of the fluid transfer to the pleural space. It can be bring about by the continuous positive airway pressure. As we see, the pressure here is positive, and through these defects in the diaphragm, the fluid continuously goes into this negative pressure compartment. So if we increase the pressure here by the CPAP, this gradient will reduce, and it will help in decreasing the hydrothorax. But alone it is not found to be useful, and some case series are there where it has been combined with pleurodesis or the surgical suturing of these defects, and then it has shown good result. Now coming to the surgical repair of the defects in the diaphragm, it can be done by the open approach, which is very much invasive in these sick patients. So the relatively less invasive approach can be tried, that is the VATS approach. It can be done alone in the form of suturing of the defects, but sometimes it is seen that because of the pressure, the fluid continuously seeps from the suture site itself. So commonly it is reinforced either in the form of mesh or the talc fluidosis is applied. So this is the largest study of the thoracoscopic mesh repair, in which the most common defect identified was the type 2 defect, that is the bleb, and it was treated by the mesh covering or the mesh with suturing. And the next most common defect was the type 1 defect, that is no obvious defect they could see. So it was treated by the mesh covering only. In this surgery, to decrease the recurrence rate, they put pigtail catheter for ICD and the BiPAP for 5 days, so as to remove as much fluid as possible from the pleura. And also there is close adhesion of the mesh with the diaphragmatic defects, so decrease the recurrence rate. And the recurrence was seen after a median follow-up of 20 months in only 4 patients out of 63. The mortality rate was quite significant, 25% mortality, and the most common cause was the septic shock, most likely because of the mesh which act as a nidus for infection in these patients. And the 3-month post-operative mortality, the independent predictors were the renal insufficiency and the high MELD score. The next mechanism can be the obliteration of the pleural space, which can be bring about by the surgical pleurodesis, where the space between the parietal and the visceral pleura is obliterated either by mechanical methods, the rubbing of the pleura, which brings about the fibrosis and the subsequently healing and the obliteration of the space, but it becomes very invasive in these patients because of the coagulopathy and risk of bleeding. Commonly, it is done by the pleurodesis by the chemicals in the form of talc or tetracycline, bleomycin, and in the form of powder or in the form of slurry, it is insufflated into the pleural space, and subsequently the patient is asked to change the postures, and there is close adhesion of the parietal and the visceral pleura in the end. And in this meta-analysis, it was found that the rate of complete response was seen in nearly 84% of these patients. However, because it requires the presence of the chest tube or the thoracoscopic surgery, the risk of complications were also very high in this meta-analysis, close to 82%. The last but the most important one is the liver transplantation in patients with refractory hepatic hydrothorax. And this is the recent study in which 82 patients of hepatic hydrothorax were analyzed retrospectively, out of which 48 were non-refractory and 34 were refractory. They were similar in baseline in the various parameters, and it was found that the high MELD sodium and the refractoriness of the hepatic hydrothorax were the independent predictors of mortality in this patient. And the median survival of the patients in the refractory hepatic hydrothorax group without transplant was only 0.26 years. That is nearly 3 months. It was the median survival of these patients without transplantation. Now coming to the benefit which was brought about by the liver transplant in this patient, in the hepatic hydrothorax group, as we see, the median survival without transplant was only 0.26 years, but after the transplant, the 1-year survival probability was as high as 0.95. So the difference which was brought about by the transplant was very great compared to the patient in the non-refractory hepatic hydrothorax, where the difference was less, and also in patients with the non-hydrothorax group, in which the difference was the least. Though compared to this third group, the patient with had no hepatic hydrothorax, the survival advantage in the refractory hepatic hydrothorax was more than 2 times. So this was also associated with this editorial in the same issue, that one should not underestimate the impact of hepatic hydrothorax on the survival before and after liver transplant, because of the tremendous advantage that the liver transplant brings about in these patients. So this is a suggested algorithm for the treatment of refractory hepatic hydrothorax. Whenever we see the patient of refractory hepatic hydrothorax, we should see whether there is any option of liver transplant is there in these patients or not. And if the expected time is less than 3 months, then one should continue with the thoracocentesis or the paracentesis till liver transplant. But if the expected time is more than that, or if there is no transplant option, then one should explore the candidacy for TIPS in these patients. If TIPS is feasible in these patients, go with TIPS and see whether this resolves with TIPS or not. If it resolves, then one needs to monitor. But if the patient is not a good TIPS candidate, or if the patient does not respond with TIPS, then the TIPS becomes really difficult in these patients. Then one may search whether the patient is having any surgical candidacy or not. And if the patient is having good surgical candidacy, then one can go for the intrapleural catheter drainage or the surgical pleurodesis or the diaphragmatic defect repair, although these are relatively more invasive compared to the earlier options. And also, if there is no surgical candidacy, then one can explore the intrapleural catheter drainage or the repeated thoracocentesis, paracentesis, with or without CPAP, midodin, octreotide, or terlipressin. However, there is very little data regarding the benefits of these CPAP, midodin, octreotide, and terlipressin in the form of only small case series and case reports. Alternatively, if the thoracocentesis frequency is less, it is once or twice in a month, not more than that, then one can also continue with the thoracocentesis as well. But if the frequency is more, then one has to again go back for searching for the TIPS candidacy. So in the end, there are more questions than answers. So one should always explore other innovative methods. For example, one can explore the utility of SGLT2 inhibitors. Some case reports are there in patients with refractory ascites and also in congestive heart failure. Because of the natriuresis, it may be helpful in patients with refractory hepatic hydrothorax as well, but it has not been tested as of now. Long-term albumin with or without midodin can be tested in these patients. Small diameter tips, 8 millimeter or 6 millimeter maybe, because in patients with refractory ascites, it has been shown that 8 millimeter is better than 10 millimeter in one of the studies published in 2018 by the French group. Maybe the earlier use of tips before it goes into the refractory stage may be helpful in patients with refractory hepatic hydrothorax as well. Ultimately, the concluding slide, nearly 1/4 of these patients are refractory. Refractory hepatic hydrothorax is associated with higher risk of liver-related deaths than refractory ascites at equivalent mild sodium. And this diagnosis should prompt consideration for liver transplant if it has not been done earlier. If the transplant option is not available, then search for the TIPS candidacy, whether this patient is a good candidate for TIPS or not. In those patients who are ineligible for TIPS, then multiple options with little evidence of benefit can be tried, such as thoracocentesis or intrapleural catheter drainage or pleurodesis, or possibly repair of the diaphragmatic defects. Ultimately, it is a complex and difficult disease to treat, and prospective studies are needed for this difficult to treat condition.